2 imaging, and 3 is tissue diagnosis. লিখছি তোমার পেপারে, চলবে তো? Now when we talk about clinical examination, this includes history taking and examination. Examination includes inspection, palpation. ठीक है? So now if we talk about history taking, now a patient comes to you with this, what will you ask? We'll talk step by step. What will you ask? Okay, before that, anything else? Patient, any particular history taking? Now we're just talking to the patient. It's important. Patient particularly, what is important? Just a second. Hello. Hi, good morning, sir. अच्छा, हाँ. अच्छा. ठीक है. हाँ हाँ हाँ. Breast cancer রিলেশন সাথে কোনো আছে রিলেশন? Basically it gives patient more confidence. মানে যদি নাম দেখে ডাকছো না, suppose you are my patient. Now I can, if I just say you আর যদি ওনার নাম, your name is বৃষ্টি, আর এখন আমি বলছি বৃষ্টি, বলো তোমার কি অসুবিধা, তো it develops more personal confidence, একটা rapport develop হয় একটা patient আর এক ডাক্তারের সাথে. So first is name এর পরে age. So breast lump এর is age কেন important? Yes. So usually আগে দেখা যেত that in postmenopausal women breast cancer is more common, but though the trend is changing, এরকম না কি premenopausal এ হয় না, এখন 25 to 30 years age অবধিও breast cancer হচ্ছে. The proportion is less, most commonly postmenopausal এ হয়, but you get a rough idea. If 15-20 বছরের পেশেন্ট এসে বলছে female বলছে I have a breast lump, so our suspicion goes more towards benign breast disease and not malignancy. So when we're talking to the patient, we're already making a diagnosis somewhere in the back of our head. ঠিক আছে? So that is about age. Then obviously gender female or male, একটা male patient কি এই complaint নিয়ে আসতে পারে? So there can be multiple complaints, or maybe it could be gynecomastia, or it could be a proper breast lump. So breast lump থাকলে it could be breast cancer. So males the incidence is very less, approximately 1 to 2% আছে, but it is there. So as swelling থাকলে it could be gynecomastia. A lot of males will come to you with gynecomastia complaint. ঠিক আছে? So age, gender, demography has any role in breast cancer? It is usually more by এটা বলে, but I don't know মানে ওর কি রিলেশন আছে, মানে কোনো সাইন্টিফিক রোল আমি জানি না, but they say it's more for developed countries. এখন তো সবারই হচ্ছে, মানে there is nothing, সবাই বাঙালি তো, তো এখন তো সবারই হচ্ছে, there is no as such criteria for developing or developed countries. But in Ashkenazi Jews, it is usually seen that they have a genetic predisposition. So Ashkenazi Jews are kept in high risk. They are kept for surveillance. So Ashkenazi Jews we need to consider. Then age হয়ে গেছে, gender হয়ে গেছে, demography আর কিছু? Yes, so we need to take the gynecological history also. So we'll start with the menstrual cycle first, মানে age of menarche, then যদি nulliparous or multiparous, then child age at first childbirth. If the menarche starts earlier and if the menopause occurs late, or if the age of first child is very late, the estrogen exposure in the body is more, and that has been seen, it is linked to breast cancer. So that is why it is very important to know whether the age and everything. And nulliparous, it is the risk of breast cancer is higher than multiparous. So that is for menstrual history. Then any other history? Yes, so breastfeeding we can take history. So there are some papers that show that breast cancer decreases the risk of breast cancer, but যদি one female is saying that I did not breastfeed the baby, does not mean she has cancer. A lot of time patient will come to you with breast lump, but there is no lump. That breast fat that's a little dense, so they feel it's a lump, but actually it is not a lump. So that just requires counseling and assurances. So history taking data, now we'll ask what what the complaint of the patient is. Also the family history. We have to ask whether there is very positive family history or not. So family history can be positive. There are a lot of family history positives. Mother, if they say कि brother had some issues, brother had some cancer. So we need to take any. It's not just breast cancer that we need to ask. Any type of cancer that they had need to be taken care of. Because it's BRCA1, BRCA2. BRCA2 has predilection towards prostate cancer also. So we need to take proper history and pancreatic cancer also. BRCA1 also has a pancreatic cancer. Three main cancers: breast, pancreas, and prostate cancer. There are more genes, ATM, PALB2, but all that I think is not required at your level. So history taking in family history is very important. Then what else is important? Family history, breastfeeding, menstrual cycle. Anything else you can think of? I think that is fine. So then we'll ask about the symptoms. So most common symptom is a breast lump. The patient will come and say that I have this lump for so many months or so many weeks. Then we'll have to ask detail about the lump, whether the lump is increasing in size or decreasing in size, if there's associated pain or not. Because see, if they say that the lump was big, it has become smaller. So then our diagnosis might change, because usually breast cancers does not decrease in size. It has never happened that automatically it decreases in size unless and until there is some super added infection that has subsided. So usually benign breast diseases could be a cyst, a complex cyst, infected cyst that was infected and now it has reduced in size, or simple mastitis infection by H. pylori that has reduced in size. So that can be the cause of. You have to ask whether the size increased or not. If the patient says that the size increased, then you know whether it increased very fast or whether it increased slowly. Because I'll come to it why which one increases fast, which one increases slowly. Then whether it is associated with any other symptom, whether there is nipple discharge. If there is nipple discharge, then usually what happens? The tumor is involving the ducts, the mammary ducts, and that is why it is also giving discharge. Sometimes patients only come with nipple discharge, so we see a very small tumor in the ducts, and there is nothing else with the patient is complaining. So associated nipple discharge is very important. Then what type of nipple discharge? So there are three types most commonly: serous, milky, and bloody. Bloody is usually associated with cancer, and the rest are usually benign. A lot of times patients they do it on their own. They will keep expressing, they will keep pressing, and then the nipple discharge comes. So that is also nothing to worry about. We have to tell the counsel the patient that you need to stop expressing. Spontaneous nipple discharge is something that is worrisome, because that means there is some pathology inside the ducts. Could be anything. Could be a papilloma. Could be ductal ectasia. Could be a carcinoma. Could be just ductal carcinoma in situ. DCI is that we call it. So that has to be spontaneous. People who are doing it on expressions are usually benign. So they need to stop that. Then if there is any other associated symptoms, could be ulceration, could be anything, redness. If there is usually redness, if they're complaining of redness and fever and swelling, so it goes again more towards mastitis or abscess, less towards carcinoma. And if the patient is also complaining of a swelling in the underarms, that is alveolar node. So that is also one of the symptoms, because breast cancers first metastasis is to the bones and then to the rest of the body. So that is what the history taking will take. What else will be asked? If they have any other symptoms of metastasis, so they could have body pain, if they are complaining of back pain, a lot of back pain, so they could be metastasis. So one of my patients came to me only with back pain. She said, I am not being able to walk, I have pain here. Then on further questioning, I found out that she has a breast lump. So we would have PET CT done and she was metastatic breast cancer. So you have to ask more about different sites of metastasis also. A lot of people have in liver. So you'll say their LFTs are not very much derange, but they'll have some issues with their abdomen. Some have in lungs. But most common symptoms are usually bony, because that is the one that is easily patient complains of pain and bony problems. So we'll have to ask about metastatic symptoms also. I think that is it. Then comes the examination part. I'm not writing now. Huh? You want to write? You can write. Okay. Then comes the examination part. So examination would be inspection and palpation. There is no role of auscultation in breast, and I think only inspection and palpation. Yeah. So inspection, yeah. How do you will starting? How will you start? You take the consent. Okay. After that. Anything you would like to do before that? Counseling about? We'll call for a chaperone. Okay, that is very important because it's a private part of the female. So even if you're a female doctor, you have to call a chaperone. Okay, because nowadays they can say no, even the female molested me. Okay, so for male, it is extremely important. You never see a breast case without a chaperone. If you don't have a chaperone, don't see. But call for anybody, call any sister, anybody who's outside, call for the opposite gender chaperone. Okay, and a lot of places, what happens, they don't have extra manpower, so they call the relatives. But relatives are not chaperones. Okay, so if you're in the court of law, the relatives' verdict will not be taken as any witness. We'll have to have a chaperone. Then what the chaperone says becomes the word of allegations. So never examine without a chaperone. So as a female, we still do it, but we should also not see. We should always have a chaperone. So you've added a chaperone and then you do the exposure, and then you see the patient in sitting position in three positions. So hand are kept by the sides, then one would be next to your waist and one would be hands above. So there are three reasons why we do it. A is when the hands are by the side, we see it in the anatomical position. So we see any distortion, whether we can see any lump, we can see if there's any discrepancy in the size of the breast. We can see there's something in the nipple. Sometimes what happens, if there's a tumor sitting on the duct, it retracts the nipple towards the side. So you'll see one nipple going up, one is normal. Then size of the breast, whether one is bigger, one is smaller. Then sometimes one big, one small is also physiological. So nothing to worry about big and small. If any lump can be seen protruding out of the breast, then any redness, anything that you see, any ulceration that you can see, skin involvement, anything that you can visually see is inspection. That is by the hands by the side. Then why do we see it while the hands are next to the waist? So you have to ask the patient to put it next to the waist and not just put it tightly. So you do it, you'll feel that when you put it tightly, your pectoralis major muscles contract. Okay. So now if a tumor is sitting just right there, what will happen? The tumor will also show some animation, show some movement when the muscle is getting contracted. So you can see on inspection whether there's a big tumor that is involving the chest wall or not. So that is one reason. Now the third is hand above. So when we do hand above, any tumor that is just very close to the skin will start showing dimpling. So we will know that there is a tumor that is very close to the skin. So that is the reason why we see in different postures, and we don't see it in only sitting position by hands by the side. So that is the inspection. Second, when the patient is raising the hand, we can also look at the underarms and see if we can see any obvious swelling that is coming out of the axilla. Then we'll do the palpation. Palpation is also done in all these three positions. Okay. In fact, palpation is also done while the patient has arms next to this waist and in a little stooping posture. These are all to see whether the tumor is attached to the pectoralis major muscle or to the underlying chest wall, even behind. So then how do we do it? Now if you give me a pen. So do you know the quadrants of breast? Quadrants? Yeah, there are 4 quadrants. So this is the right breast, this is the left breast. So this is the upper outer quadrant, upper inner quadrant, lower inner quadrant, lower outer quadrant. Similarly, and this is the NSE. So always examine in 4 different quadrants, and NSE is to be examined separately. Okay, this is called as a nipple areola complex. Okay, so always check, never check the breast as a whole. First quadrant, then second, then third, go in serially. So you and make it a point from starting in clockwise fashion from upper outer quadrant to inner to lower inner. Then that way you will never miss anything. And at last you see NSE. Okay, and then you will see the axilla. Okay. So if we talk about breast cancers, I don't know the exact numbers. I think 60% of the tumors are seen here. This is somewhere around, I think, 8 to 10%. And then comes, so most common is upper outer quadrant followed by lower outer. This I don't remember the values, followed by lower inner quadrant. So majority of the patients you will see in the upper outer quadrant. But that doesn't mean that you can't find tumors here. You do find tumors here, but I'm saying if we do an audit of all the breast cancers in the world, we'll see majority of the patients have tumors in the upper outer quadrant. So we'll do it in a rotatory fashion with the help of 3 fingers of our arm, not with just the tips of the fingers, but with the entire portion of the fingers. Okay, we'll do it in a clockwise fashion. We'll go from gentle to deep. First, we'll do a superficial palpation and we'll see if we can feel anything, and then we'll go to deep. So what happens? This gains the trust of the patient. Okay, so if suddenly you just go deep, so the patient will experience pain. You're like, oh, don't touch me. I'm having pain. But when you're doing superficial inspection, patient also gets used to your inspection process. So you check for that. Now suppose you found a tumor. So now you'll wait and you'll again examine the tumor. Inspect the tumor. How big is the tumor? So just for a rough approximately size, you can say it's a 1 centimeter tumor. So 2 centimeter tumor, small. This is approximately 1, 2, 3. The more you examine, the more you understand what is the approximate size of the tumor. So see what is the rough size of the tumor. Check for the margins, whether you can well-defined margin, smooth, round, oval, or whether it is irregular. Usually, a smooth, round oval is seen in benign breast diseases like fibroadenoma or any cystic lesions, and usually irregular margins are most commonly associated with carcinomas. Then you see whether it is attached to the skin. So for that, you do a pinch test. Pinch the skin and you see whether the tumor is attached to the skin or not. Sometimes you will see that the skin has slight tethering or slight dimpling. Because the tumor is there, it is not involved the skin, but it is pulling the skin very close to the skin. If the skin is involved, then you will not be able to do this pinch test. You will not be able to separate the tumor from the skin. So skin involvement is important. Then last is involvement with the chest wall. For that, like I said, you have to contract the pectoralis major muscle and then you move the tumor in 2 different directions. So pectoralis major muscles, what is the direction of the pectoralis major muscle? Anyone knows? Yes. So this is from the clavicle lateral towards the sternum. Okay. So once you will rotate the tumor in the direction of the pectoralis and one would be perpendicular to the pectoralis. So that we will understand whether it is attached to the muscle or it is not attached to the muscle. If it is not attached, it will freely move. If it is attached, you will not be able to move while the pectoralis major is contracted. So the moment it involves the pectoralis major muscle, it becomes an advanced disease. So you'll see if this is the breast. Okay, this is the chest wall. Now suppose it's a 2 centimeter tumor here. This will not involve the pectoralis major muscle. This is still T1. But if suppose there is a 2 centimeter tumor at the intramammary fold, this is the intramammary fold. Okay, the fold, you know what is an intramammary fold? So if this is the breast, suppose like this. So this part of the breast is the intramammary fold. So now this is very close to the skin and this is very close to the pectoralis major muscle. So tumors which are closer to the IMF, they have a tendency to involve the chest wall muscle faster than a tumor here. So this has a lot of breast tissue. This here has less breast tissue because it is ending here. Okay, so that is the inspection part, and then we'll check for the axilla. Whether in axilla, whether we can see any node palpable or not. Now axilla also is divided into 5. Anybody knows what we have to check in axilla? What are the different compartments of axilla? So how do I draw this? Okay. So if suppose this is the breast, this is the part of the axilla. Now axilla I will zoom in and show you. So this becomes anterior part, which is just behind. So pectoralis major muscle goes like where? The pectoralis goes like this, okay, behind the breast. This is the clavicular attachment of the pectoralis, and from here this is the anterior axillary line. So this becomes the anterior compartment. If this is the hand, then this becomes a posterior compartment. This is a shoulder. This becomes a superior. This becomes the inferior. And over here where the clavicle is ending, this is over here we have the costoclavicular ligament. This becomes the apex, which is right up till over here towards the humerus, like just starting of the shoulder, clavicle, and just at the depth. If you want to see yours, just where your fingers are ending upwards. Okay, so this is the apex. So anterior, posterior, superior, inferior, and apex. So we have to examine the nodes in all 5 sections. Usually early breast disease we see all of the nodes here. Usually these nodes are not palpable. Apex is also palpable only when it is very advanced. Okay. So then we palpate the axillary node and we mention whether the node is palpable or node is not palpable. So after the examination of the breast, after the examination of the node, we also check for the supraclavicular nodes. Okay, so whether the supraclavicular nodes have any node that is palpable. Now, how do you check for this? Suppose I am the patient, how will you check for my supraclavicular nodes? And then we taught you this, how to check. So if you stand behind the patient, okay, then you'll see this fossa, and from behind you'll have to touch and check it. Okay, so you can also ask the patient to shrug a little. So what happens? It creates a space. Okay, but you have to stand behind the patient and need to check for the SCF. After checking for the SCF, you also have to check for distant metastasis. So you check for the abdominal examination. Just do a rough examination. Don't have to do thorough examination. Check for the liver whether it is enlarged in size. Then check for any bony tenderness. Just overall do a rough respiratory examination. Whether you can see, you don't have to go in depth because in depth abdominal examination is only used. Respiratory is only used. Just do a superficial palpation. Check for any enlargement of the organs with Raza. So that completes your examination. So now suppose we have a 3 centimeter tumor, node is also palpable. What would you do next? Our examination is complete. Yeah, biopsy comes later, we'll do imaging first. So in imaging, we'll do a mammogram and we'll do an ultrasound. Okay. So multiple things that mammogram shows, ultrasound doesn't show. Mammogram shows calcifications, shows tumor size, shows axillary nodes also. But ultrasound will show you more. The sensitivity of ultrasound for axillary node is more compared to mammogram. Also, ductal involvements are seen more in ultrasound than in mammogram. If there's a cystic lesion, that is also seen better in ultrasound than in mammogram. And so we have to do both. Never do just one single test. After that, we'll do a biopsy, like you said. Would you do an FNC? So you'll do biopsy or FNC? FNC. Okay. Why not biopsy? So in exam, you always have to say biopsy. Okay. So in test, there is no rule of FNC. We do FNC in sometimes when we have less of resource, less of money, patient has no money. But FNC has no role in this era. Why? Because see, FNC does not tell you a lot of things. If we talk about biology of the tumor, I'll probably take a separate class for this. So, if you know, do you know about estrogen receptor, progesterone receptor, HER2? Okay. So there are 4 types of breast cancer: luminal A, luminal B, triple negative, and HER2 enriched. So luminal A ER/PR is positive, this is negative. Then there is a grade and a KI. Grade is 1 or 2 and the KI is usually low. Whereas in luminal B, ER is positive, PR can be positive or negative, HER2 can be positive or negative. Grade is usually 3, KI is usually high. In triple negative, everything is negative. These are usually high. HER2 enriched, only HER2 is positive. This is also high. Now in these 2 patients, what happened? Patient takes chemo first, which is called as NSCT, followed by surgery. And in these 2 patients, luminal A is always surgery first. Luminal B, depending on the size, patient, everything we decide. So based on this, your further treatment depends. So if you do an FNC, you will not do any of these. So how will you know patient will need chemo first or will need surgery first? So for that, you need to do a biopsy, which is a core biopsy, which is done with a 14 gauge needle. We take some biopsy and we send it for the sample. So that's for tissue diagnosis, and we do a PET scan to see whether patient is metastatic or not. The moment the patient is metastatic, patient becomes stage 4. And in breast cancer in stage 4, there is no rule of surgery. We only give chemotherapy. So that is how we diagnose a breast case. Then management, maybe we can discuss in the next, because management itself is also very huge. But this is how we approach a breast lump. You have any questions? Ask. So screening test is there, which is a mammogram and an ultrasound, but it is done after 40 years, not less than 40 years, because less than 40 years, the breast is usually very dense. So you'll see mammogram images are fully white, only the breast fat can be seen. And calcifications are usually very small, the malignant cells, very thin, small micro calcifications. So you'll miss out. So you do it after 40 when the density of the breast usually reduces. There is no rule of mammogram less than 40 years unless patient is a diagnosed case of malignancy, then we do it. Benign? No, no. It can be benign, it can be malignant. So there are multiple benign breast diseases. They can be fibroadenoma, they can be benign phyllodes, they can be galactosele, any kind of mastitis. Now, mastitis is also multiple types. There is granulomatous mastitis, tuberculous mastitis, bacterial mastitis. Then there is Mondo's disease. So benign breast disease also is a lot. Fibrocystic breast disease. So that itself in itself is a big topic. I think that is bigger than breast cancer, I would say. Benign breast disease also is huge. Cysts are also multiple types. There's simple cysts, there's complexes, there's multiple types. Actually, benign breast disease is much difficult to treat than carcinoma. Carcinoma, what happens? We have set guidelines. We know we have to go about this. In benign breast disease, now most of the things depend on counseling. Like a small 1 centimeter fibroadenoma which a patient has, you have to do nothing. Matlab, you can just follow up the patient till life. It will not increase in size. There is no point removing that 1 centimeter fibroadenoma. Clinically also you can't palpate. So you end up taking out breast parenchyma more. So you have to understand which patient needs surgery, which patient is more anxious, doesn't need surgery, no need to do. All fibroadenomas do not need surgery. But people have this notion that any fibroadenoma they want to operate. Cysts, they don't require surgery. You can just simply, if it's a big cyst, do a USG guided aspiration. So nowadays, surgery is limited to very limited number of cases.